We'll move to the next presentation. That is from Dr. Manas Panigrahi. He's going to talk about the medical practice-based evidence versus evidence-based medicine in degenerative spine surgery. Dr. Manas.
Thank you, Dr. Bhattok and Dr. Manoj. Um, and I'd like to thank Professor P.K. Sahu also for giving an opportunity to speak on this topic. Uh, this is a topic which I routinely don't speak. So I'll present what I have understood about evidence-based medicine, though we practice every day, but it is difficult to teach EBM. And especially it's more important in spine degenerative disease because there are a lot of controversy in diagnosing, treating, in different modalities of treatment, whether to fix or not. All that is why it is very relevant in evidence-based medicine in treating spinal diseases. This is a graph which is show that when we complete our post-graduation, we are up to date with knowledge. But then over a period of time, as we practice, our clinical skills and experience goes up, but our knowledge goes down. The aim of this presentation is how to fill this gap, that we have up-to-date knowledge and practice with good clinical skill and use our experience for the best for the outcome of the patient. Earlier, if you look at 20 years ago, doctors had the authority 20, 30 years ago, and despite a lot of journals, but now it is not true. Now we should treat with the best evidence, otherwise we do not give the best treatment and we also can end up with medical problems. So why do we need evidence-based medicine? The evidence-based medicine is not it is because like pharma, like bad pharma, where they come out with a lot of drugs without adequate trials and then land up with complications of the drugs. Spine surgery has a similar concept because many people believe that the spinal fusion is industry driven. So EBM is very important over practice, what we practice in or what we believe in our day-to-day treatment. Now, this study of RCT done in 1980, where they studied the introduction of antiarrhythmic for arrhythmia patient. Though it was told it is a very good medicine, but when they did the RCT, they found out that the mortality was very high and they had to be discarded. So it is very important that one has to do some trials or studies before accepting a new surgical treatment, either medical treatment or a surgical treatment. Evidence-based medicine is not very old. It's not even 50 years. It started in 1980, where Professor Sackett, from Canada, he proposed that evidence-based is a new way of teaching, learning, and practicing medicine. And so we are yet to celebrate the golden jubilee of evidence-based medicine. And it depends on three factors: the physician's skill and experience, the patient's requirement and information to the patient, as well as patient value and ethics and the information available. So one has to integrate all three to practice evidence-based medicine. But then it's not easy to have all the information. FDA came in around 1960-70, and evidence-based medicine came in 1980s. But if you see from 1970 onwards, the number of publications is are so many that it is very difficult for clinicians to go through everything to identify what is the up-to-date knowledge, the present evidence to treat a specific disease. So you have many journals, you have many, per day you have 2,000 publications. So it is difficult to decide which is the best one. And now we not only have to read, but also have to learn the publication which has a good level of evidence. All publications cannot be taken as the evidence that it's that we have to follow. one has to beware of textbooks because textbooks are not our opinions, expert opinions like what we practice. So one has to uh, actually decide which literature should be applied in practical medicine. Now, this paper which came in 2016, now they compared surgical versus conservative treatment of lumbar disc herniation. This is a prospective cohort study. And what they concluded was at the end of 1 year, whether one does a conservative treatment or a surgical treatment for pain, they had similar outcome. It's only faster relief was there in the early period, in the first 3 to 4 months in surgery, but at the end of 1 year, both are similar. So as a spinal surgeon, one will get confused that what is the best form of treatment, and we need guidance how to treat a particular patient. And many times, a person who has just finished his MCH, seeing all this literature, he may get confused also. That is where evidence base comes to the rescue of practicing neurosurgeon in nook and corners of the country. But this paper, which is a good paper analyzing how the research in spinal surgery helps in practice of medicine. This came in 2014. The first thing for approving or accepting a study is to know what are the study design in that paper, whether it's a case series or a case control cohort, or it's a RCT or a systematic review. A case control is something, a series of patients with a particular disease or condition with match control. Cross-section is what we do for many of the papers what we present. But the ideal thing is to do a randomized trials where you have a control group with or without treatment. But then in spine disease, it is very difficult to have a randomization because the patient has to accept that if that is the standard of protocol, everybody follows, and then we cannot tell him that you cannot take treatment. So in spine disease, we do not have many RCTs in spine disease, and we land up with either cross-sectional or longitudinal studies, which probably has to be accepted as a level of evidence in practicing medicine. But this is just a cross-sectional study of normative values for cervical lordosis. This is because there was no study of Indian population of the range of movement we did for a population of Hyderabad, and we found this was the normative values. What are the advantages of each one? Though RCT is the best one it's the prospective nature and it reduces the bias, but it is high cost, it's expensive, and it takes a lot of time, and there are a lot of it is difficult to have to avoid crossovers. There is high chance of crossover because one can, in spine disease, one cannot prevent a treatment to be given to a particular patient. Say in a short or randomized non-controlled trial, one can think of systematic review. Systematic review is a summation of available literature. That's also a good level of evidence to have to practice that medicine. The second level will be cohort study, and the least will be case series or experience, what expert opinion, what we do day-to-day practice for a particular case. So if you classify it depending on the study design, the level of evidence, an expert opinion or a case report is has a level of evidence of 5, whereas RCT has the best value. And as I explained, RCT in spine disease is difficult. Level 2 evidence is or systematic review of studies is good enough. But what has to be looked at is there has to be at least 80% follow-up to tell that it's a good evidence. But if there is less than 80%, it is a poor quality RCT, or it can be taken as level 2 evidence. So one has to understand while studying a paper whether the study design is good or not, and the level of evidence is good or not before promoting that concept to others or practicing that on your patients. It's important that in the paper they also have looked at the outcomes of the surgery, like when they have used proper outcome scores so that it can be compared with other types of treatment. And if they have not used probably, then it's not a good paper. So here, if one looks at the pyramid of the evidence, the expert opinion, what we do, has the least level of evidence, and in spine disease, probably the systematic reviews, probably the conclusion of this will have a better value in using that for patient clinical practice, because systematic review is reliable, and it has minimizes a lot of bias. And if systematic review is added with statistics, then it becomes a meta-analysis. So meta-analysis, the conclusions of meta-analysis also is a good evidence to translate the practice into for patient care. Though the gold standard is RCT, it is not possible in spine disease because it is expensive and its prolonged treatment, its funding is difficult, and it's difficult in spine disease. So how do you practice evidence-based medicine? The first step is to ask a focused question. Like, I'll give an example of what we do for our patient. Like, all of us know that if you have a compressive myelopathy, like this patient who came with compressive myelopathy, and all of us know that it needs a posterior decompression, but one can do a laminectomy, one can do a laminoplasty, one can do a laminectomy plus lateral mass fusion. So what would be the ideal method of all the three? Because if we ask three group of surgeons, they will tell that three different ways of treatment. But when you look at outcomes, so we ask that what is the best, whether you do follow laminoplasty or follow fixation or just do a laminectomy. When you look at the literature, that 12 months follow-up, there has been no significant difference whether you fuse or do laminoplasty or do laminectomy. Once we have identified a question, a focused question, then you have to find out the evidence. What are the evidence available? Whether we can do a better, we can increase the better outcome over the present available evidence. So we looked at that. Why does that laminectomy, laminoplasty, and fusion does not have any effect? Now, one paper we saw that whenever there is laminectomy, there is an increase in kyphosis, and many patients have either loss of sagittal balance. So whenever there is loss of sagittal balance, it's only decompression is not enough, because when there is an increase in kyphosis, the cord gets stretched. The stretching of the cord causes worsening of deficit. So that is why whether we do anything, laminectomy, laminoplasty, they do not recover. Now, this paper, they came that in addition to that, when we do not take care of the junctional instability, if you're doing a cervical laminectomy, the junctional instability can happen in C7T1. And that again causes, because this becomes one full block, and this is one, thoracic is one block, there is again a junctional instability and causes stretching of the cord. So then these patients, they recover for 1 year and they worsen later. So here from this, they promoted that one has to do fixation of C7 or T1 when you do a laminectomy, so that they do not have delayed deterioration, because they avoid stretching, or we can retain or regain the sagittal balance that itself has a longer, better outcome. So from this, we took an hypothesis that sagittal balance has to be considered in compressive myelopathy. It's not only bony decompression or only limited fixation. And we applied this evidence in practice. So we started earlier, we used to do laminectomy and just fixation. And then we started doing fixation, including C7T1. We did a transvestital screw, so which includes fixation of T1 that took care of the junctional instability. So, but then this is not randomized. This was the retrospective data we took out. And then because of the evidence, we followed that, we started including T1 in the fixation in group 2 from 2017 onwards. And then we used Dennis Pin score, the Japanese score, and measured the T1 slope angle also in all the pre and post-op CT scan. Now, what we found was in group 2, where we did T1 fixation, the statistically significant difference in neurological outcome. The motor recovery was better, but the pain, there was no difference in the pain, relief of pain, but neurological recovery was better. And the T1 slope angle, when we measured, we could achieve normal physiological level. And this, finally, we published it is accepted for publication this year. So in conclusion, evidence-based medicine is not only important for spinal surgeon, but as it involves cost of treatment to the government, it also important for health policymakers. If you create evidence that will help them to allocate funds in treatment of spinal disease. And high quality evidence in spine disease is lacking as it is difficult to RCT, but prospective observational cohort studies may be more appropriate, and meta-analysis and systematic studies also can be taken as a good quality of evidence to practice medicine. Case series and case control study designs can be used for rare disease and new treatment options. And the last point, that in this 21st century, one who cannot critically read a study and is not prepared to make a conclusion that this is good or not, probably it's like not knowing blood pressure or examining or auscultating the heart or doing a neurological examination. Thank you for your attention.
Thank you, Dr. Manas, for an excellent presentation. Very informative lecture. Any questions from the faculty members?
Just a comment, Batuk.
Yeah, yes.
I think this is a very important point to be made, which Manas has made. I think initially he did point out that evidence-based medicine is only as good as the quality on which the evidence is based. That is something we need to remember. It's only based, if the quality of the evidence is poor, then the outcome, the level of evidence which we get will also be poor. And many times the results of randomized control trials are not reproducible in our day-to-day practice because RCTs have strict exclusion criteria which are not applicable in our day-to-day practice. That is one reason, for example, like not with reference to spine, there are other recent publications, spine also, about ventral versus dorsal decompression. Both are equal. That's a study that came out in JAMA. So that the study says it's both are equal, but they have excluded patients with segmental and global cervical kyphosis, which means they have excluded patients who are eligible for anterior surgery. So that particular caveat they have not mentioned in the conclusion. So that is where the last point, which last slide of Manas comes in. If we do not analyze the study properly, we may end up misinterpreting the study.
Yeah. Thank you. Thank you, Professor Muthukumar. And thank you, Dr. Manas, for an excellent presentation again.